Evening, everyone. I welcome you to today's CPC session on an interesting gynecological case. It is my pleasure to introduce our clinical discussant for today's CPC. Professor Amita Suneja serves as principal and as HOD of Obstetrics and Gynaecology Services at UCMS and GTP hospitals. She has held many prestigious positions in the Association of Obstetrics and Gynecologists of New Delhi, as well as National Association for Reproductive and Child Health Care of India. She's been the immediate past president, chairperson of the Oncology Committee, as well as an editor. She's an international expert with a fellowship, WHO fellowship in gynecological oncology from MD Anderson Hospital, and is the recipient of numerous awards which are listed here, as well as she has many publications and book editions under her belt. Please accompany me in welcoming ma'am. Welcome ma'am to the session. CPC very good evening, and thank you for giving me this opportunity. I'm grateful to the department. So I will be the clinical discussant for a case which I have tried my best to reach at the diagnosis, but I'm not so confident about whether it's right. So I have just copied and pasted the case history and examination as well, so that there are no changes in that. So chief complaint of the patient, a 26-year-old young female, was abnormality in the routine pregnancy, and she was in normal good health and was diagnosed with the abnormality in cytology for cervical cancer screening in April 2020, which was 1.5 years back. She had previously experienced a episode of which was circulating, and the initial colposcopy was inadequate. And subsequently, she underwent examination under along with endometrial aspiration and bone biopsy, which was 2 months later than the cancer. Then she self-referred to AIIMS 8 months ago. 8 months ago, that means it must have been January 2000. There was no history of false swelling, discharge for vagina, AUV, or rectal bleeding or discharge, and no history of loss of weight, or bladder habits. There was no swelling anywhere in the body, no symptoms suggestive of CNS or seizures, loss of consciousness. And menstrual history was also unremarkable. At 10 years, cycles were regular with normal. And there was history of one episode of heavy menstrual bleeding 11 years ago, that was 15 years old, which required hospital admission and blood transfusion. And now there is no history of disability. Obstetric history, she got married at age of 23 years, but is single, separated 1.5 years back. And there is a history of missed abortion 3 years ago, which I suppose is abortion. And there is no history of any oral contraceptive or ICD insertion. Past history, not significant, no chronic illness, surgery, prior pregnancy, and family history is negative for any malignancy. So if we see the summary of the case before coming to AIIMS, the highlights are that she is young female, 26 years, married, parents legal abortion 1, had 2 episodes of postpartum bleeding, but had a normal pap smear 1.5 years back, routine screening, and colposcopy was done, which was inadequate. Then she underwent under anesthesia examination and endometrial aspiration and punation. And it was not clear whether punation was 2 months later or every whole procedure. I suppose it was EUA, endometrial aspiration, and punation done at same sitting, which is 2 months after the abdominal aspiration. No mention of vaginal involvement has been mentioned history, and she said that the claims maybe in January. And the AUB history at age of 50 years, I suppose it is unrelated. So one thing I can say from it, the previous history, is that probably she had glandular abnormality. Now why? Because endoaspiration has been done at 26 years. Now if we see the glandular abnormalities in the pap smear, this is the classification. An indication of doing endometrial aspiration is if she is more than 35 years. But she is 26 years. That means either there were endometrial cells in the pap smear, atypical cells, or there was endometrial cells suggestive of adenocarcinoma, or these were the cells, glandular cells, which favor neoplasia. And another indication of doing endoaspiration with pap abnormality is if she is high risk for endometrial cancer, like she has PCOS, she is obese, there is a family history of Lynch syndrome, then we do endoaspiration earlier. Now, so most probably in this patient, I felt she could be AGC favoring neoplasia because the classic description in the guidelines is that you find AGC favoring neoplasia, then you do colposcopy and endometrial sampling. If that is negative, then go ahead with coagulation. So that three procedures have been done. So we suppose, but difficult to say what exactly was the abnormality. One thing is sure, it is glandular. So at this point of time, now if I make a list of differential diagnosis, which is based on history at this young age, I first keep the possibility of pre-invasive lesions, which could be HPV associated or HPV independent. Second, I'll keep the possibility of microinvasive lesion. Third is invasive lesion, many types, status, adenocarcinoma. However, and the rare possibilities, this is coming from AIIMS Delhi, for diabetic or rare possibilities, so maybe lymphoma and hematopoietic disorders. And then we cannot rule out inflammatory and benign lesions. Now, tuberculosis can be anywhere, everywhere, and they are masqueraded of malignancy. So, RTI, conventional RTI means the granuloma and myelin in the cervix can lead to this type of abnormality. They can be cellular ATPR. And in the benign lesions, we can have microglandular hyperplasia, which can be atypical also, endocervicosis, tuberculosis, and tuberculosis. So these possibilities we have, and then one by one we'll see where we reach. Now, general physical examination, which was done at AIIMS, practically no abnormality, no paralectal cyanosis, periodema. BMI was 25, slightly overweight. Bilateral breast was normal, no enlargement of any cervical, supraclavicular, axillary, or inguinal lymph nodes. She was afebrile, pulse rate 77 per minute, regular sinus rhythm, no delay, and blood pressure normotensive, and the respiratory rate was 16 breaths, and SpO2 was also normal. Systemic examination again essentially normal, CVS, respiratory, CNS, abdominal examination, no free fluid, no organic belly, no mass. So that was negative. And local examination point to be noted is that external genitalia is normal in the appears that is normal. And postpartum examination revealed cervix is flushed. It was post-coronation case, and it was hyperemia in vagina was also. So that is which one positive finding I considered in addition to coronation, the vagina was hyperemic. And per vaginal examination showed that it was a post-bone cervix which was firm in consistency, smooth and flushed with vagina. The uterus was normal size, antiverted, and vaginal walls were smooth with regular reverses. That means no granularity was felt, no cysts were felt, no pulsation was felt on PB examination, and even PS did not reveal any vaginal abnormality except hyperemia. For rectal examination, the causes of pain, no mass, course in the hospital, she was subjected to colposcopy and vaginoscopy, which showed dense osteoid covering entire residual cervix and all walls of the lower under the vagina. So there was dense osteoid. The lesions were found to be extending into the inner cervix. Cervix and whole length of vagina showed dense yellow staining on the urethra, and sweet score was 10 by 10 in multiple biopsies were done. So, following multidisciplinary discussion, the patient underwent surgical procedure for definitive treatment and post-operative period was underwent. So, and the investigations given to me were that the contrast enlarged on 10th January showed no abnormality. Maybe it was she came with the report of exposed, and the whole body PET CT has been done twice. One on 5th 4 and second on 17th 4 at a difference of 12 days. And both the PET CTs reported as no definitive or any active metabolic lesion visualized in cervix, vagina, or elsewhere. GI endoscopy upper and lower was normal, and biopsies have been taken twice. Cervical biopsy and vaginal biopsy taken on 31st, probably that was the date of endoscopy, when multiple biopsies have been taken, and exactly after 1 month, the biopsies were repeated. So now these are the colposcopic images provided to me. I have enlarged them, and if you see the first photograph, it shows, I won't say it is inadequate because bleeding is not so much, though there is bleeding on touch, but it is type 3 transformation. And we can see dense acetoid epithelium and with tiles of the epithelium. But we can see the clear margin also. And that margin, this seems a normal mucosa. So maybe everything is not in continuity to vagina. There is a field effect. In between, there is a normal tissue. So that is first photograph. Colpo photograph second also showing the same thing, but you can appreciate the dense acetowhitening near the posterior fornix, lateral fornix, and these are definitely abnormal. However, there is no abnormal angioarchitecture. You can't see any post conditions, atypical vessel, which is landmark visual invasion. And this is a beautiful slide showing the involvement of posterior vagina, and it's like a white bed sheet. And you see this lateral margin. It is so raised and sharp, very suggestive of high-grade lesion. And though there is a variation, like this epithelium is quite pathological, and this is not so. So there is involvement of vagina, and I said it is below 1/3 of vagina. And these are the PET CT images which were given to me. And this is, I consulted my radiologist colleague, and according to them, these are the images of the perineum. The first is at the level of introitus, second is at the level of perineal image, and at the which actually highlights the urethra and vagina. Center, there is no FBG uptake, you see, and but some this uptake is there in the urethra and the anal canal. And then this is at the level of pubic symphysis on the base of the bladder, inferior aspect of the bladder, and there is subtle FDG uptake in the excreted unit. So her reporting was that there is no significant uptake of FDG is seen in the images. However, better comment can be made if SUV values were provided. Those have not been provided. And second comment which she could make was that probably the dose of FPG contrast given was less. Maybe the reason that they repeated the accuracy 12 days later, the PET CT. That could be one reason of repeating PET CT 12 days later to have. And routine investigations were given to me, and one was on 3rd April. She had come here in January, and then two repeatedly 20th April and 23rd April, then 1 month later, 16th May. And counts, hematocrit, everything was normal, nothing abnormal in this. Neutrophil count was more 83% on 20th April, and then it recovered later. You see the neutrophil counts, and the lymphocytes decreased. Then another biochemistry which said LFT, KFT, everything normal, except that total protein, if you say 20th 4, it was low, as well as the albumin. and on 23rd. So I thought probably this is the time she must have undergone surgery. And then I did mail to Dr. Anshul, can you provide me date of the surgery? And she replied that it was 19th April. So 19th April she had a surgery, and these are post-operative investigations quite possible that they will be later. But 16th May investigations are on. So let's see the timeline of the investigations. CT MRI has been done on 10th January. Colposcopy was done. She came in January to, of course, I didn't take the conation before coming to AIIMS. Colposcopy was done in AIIMS on 31st, maybe or earlier, January 24. Cervical and biopsy, vaginal biopsy, multiple, have been taken on 31st January, then repeated after 28th February. GI endoscopy date has not been mentioned, but it is normal. Whole body PET CT done twice, and then serum biochemistry serum has been given. So that is the timeline of investigations. And now to completely summarize the case, that she is 26 years old, married, para 0A1. Pap smear showed maybe glandular abnormality in April 2023. EUA endoscopy conation. After conation, there was a residual disease. And colposcopy revealed the endocervical, ectocervical, and vaginal. There was suggestion of high-grade lesion. Cervical biopsy and vaginal biopsy. The endoscopy of GI has been done. Can give me some notice that it was negative. And imaging, including MRI and CT, negative. And surgery has been done as definitive treatment of April. Maybe so many times biopsies have been taken, or this imaging has been done before the surgery. Maybe the attempt was to rule out inflammation. And so let's come to my original reading. Now, because the surgery has been done as a definitive treatment, I rule out inflammatory lesions. I rule out benign lesions. So we are left with pre-invasive, micro-invasive, invasive, and so then let's see what are the malignant lesions which are PET negative. Now, tumors with low metabolic activity will not be sensitive on PET-CT. Then slow-growing tumors like some types of indolent lymphomas, marginal zone lymphomas, T-cell lymphomas are not picked up on PET-CT. Then the small lesions, like if the it's less than 1 centimeter malignant tumor, may be missed, but with better resolution of the machines, it is less than 5 millimeter lesion, may be missed with PET-CT. And certain histological types like mucin secreting tumors, they because of relative decreased cellularity, negative on PET-CT. Then metastatic mucinous tumors, it's very common finding that if there is lung metastasis of a mucinous carcinoma of breast, it is not picked up in PET-CT. Metastasis from mucinous GI tumors also PET-CT. The metastasis from other tumors is interesting to note that renal cell carcinoma, ductal lobular breast cancer can also be missed. And carcinoid tumors mostly have uptake ranging from 1.1 to 11. So 1.1 maybe it is missed sometimes, and usually the benign lesions if you see the SUV is less than 2.5. So if the tumor has lot of necrosis, then again the PET-CT will be negative. Now in this situation the PET-CT is negative. That means there can be a possibility of malignancy if we have one of these conditions. Then coming to the point why GI endoscopy, that was quite mind-blowing. And then let's see what are the conditions where cervical and vaginal lesions have relation with GI tract. And so very common thing is if we have metastasis from GI tract to the cervix, it is very rare. But it can occur if many times their case reports. The signet cell on the family, then you should think of metastasis from GI. Second, if it's a mucinous cervical glandular intraepithelial like gastric AIS, non-associated HPV, or HPV associated AIS, intestinal type, or the special varieties type, then there can be, we can think of GI lesion. in these cases. And the very distinct HPV independent entity that is called atypical lobular glandular endocytosis, atypical LEGH, and it is associated with pure gender syndrome. So GI endoscopy becomes essential in that case to rule out. And then in frank invasion adenocarcinoma mucinous type, again the PET-CT can be negative, GI endoscopy is indicated. And then many times if you find adenocarcinoma cells in pancreas, and you don't find adenocarcinoma cervix, then you have to find out extra uterine adenoma. But in this case, we have the findings in cervix. Lymphoma, again, that insist keeping it with me. Then rectal mucosa, many, there's a field effect. So I doubt whether valvoscopy was done or not. Because we should have done valvoscopy to find out cervix is involved, endocervix is involved, endometrial we have not involved. Then vagina is involved. There is quite possibility that vulva is involved and the anal canal is involved in this stroke by region. So anal canal probably we have not done with acetic acid, and valvoscopy also findings have not been provided. So we have to ensure that rectal mucosa is not part of the field effect, and but still there can be clear cell carcinoma, adenocarcinoma, HPV associated malignant lesions. So probably any of these can be the reason for doing cervical GI endoscopy. So at this stage, I rule out very clear. There's a lesion on colposcopy and vagina, and it is not picked up by PET-CT. So I think it is epithelial and limited to epithelium. And the PET is negative, though few lymphomas are PET negative. But let's mostly it is detected, and it's a very slow course of disease. Started in April 23, 1 year after she had been given treatment. Lymphoma would have progressed. They would have been lymph nodes, and biochemistry is normal, and surgery is the only treatment given. Chemo has not been given, then we strike it out. Second group, pre-invasive, is very much there in the list. It can be HPV associated AIS with or without high grade cell with high grade vein. So that is can be is a possibility, or it is HPV independent AIS, that is gastric AIS with vaginal atypical adenosis, or with or without microinvasive. This will remain. Any type of glandular lesion I diagnose in vagina, there is a possibility of microinvasive carcinoma which has not been picked up on PET-CT. And again, we cannot rule out invasive. Adenocarcinoma, clear cell with vaginal extension. Squamous cell, I will keep it. Basically, it is adeno, especially the mucinous and the clear cell. So, coming to now the two diagnoses of pre-invasive lesions. HPV associated AIS, the classification is usual type, or even it can be intestinal, or it is special variety that is stratified multi-layer intraepithelial lesion, and 10% of smaller invasion, and then mucin stratified mucinous intraepithelial. And HPV independent AIC, this special variety gastric type AIS, and we can have atypical. Now, which is more likely? Let's see. In points in favor of HPV associated AIS, usual type of intestinal type, with vein 2 or 3, that is called hybrid vein. Now, it is a glandular lesion, and AIS extends to the endocervical canal. So, our case is glandular lesion extending into the endocervical canal. 50% are associated with high-grade cell. So, vaginal involvement to me looks like a high-grade cell vein. So, if there is a high-grade cell, vein is also HPV dependent. So, maybe the vaginal involvement is high-grade vein along with SC, along with AIS. And mostly are asymptomatic. This patient has no symptoms except 2 small episodes of postpartum bleeding, no discharge, no mucinous discharge. But then AIS usually does not explain the GI endoscopy. But if it is intestinal type, then we can explain GI reason for doing GI endoscopy. And then points against it are that mostly the age group is around mean age is 38 years. This patient was 26 years. And 38 years why? Because the invasive cancer occurs around 59 years of age, and AIS occurs 10 to 15 years younger than this. But there are always exceptions. That's not very strong, which goes against it. Another lesion, smile, stratified mucinous intraepithelial lesion. Now, this is mucin groups. So we do think GI endoscopy has been done. This is a strong possibility. It's my diagnosis. Then it is a subtype of AIS. It behaves like AIS. And at low magnification, you find as example SC, and this does involve the endoscopic glands. But at high magnification, we find intracytoplasmic mucin. It may coexist with high-grade C, which I think there is extension of high-grade C, and it also can exist with AIS children, and along with the 10% are certified users intraepithelial carcinoma. So maybe it is harboring in frank invasion of its smile with high-grade C with focus on invasive cancer. Now, gastric type AIS is HPV independent, and the age range fits into this. It occurs over a wide age range, 25 to 74 years, and our patient is 26 years. It has mucin component, and tendency to extend into anticervical and endometrium, and it does not form visible mass. So there is no mass registration or ulceration. It is seen as an epithelial problem. So it is asymptomatic, only findings many times in normal pap smear. And now, if you see the latest literature, this is a very good review article published in 2024, which is saying that gastric type glandular lesions, female genital tract, excluding the cervix, emerging pathological entities. The cases are being reported at increasing frequency, and surgery is the treatment of choice. Even for AI surgery, choice has been associated. So that is also a possibility. And atypical lobular endoscopic glandular hyperplasia. Typical one is not it's not malignant or pre-malignant, but if it is atypical, it forms a pre-malignant lesion. It involves the upper endoscopic canal, might find your yellow mucin or cracks in gastric differentiation, and it may be associated with multifocal lesions of female genital tract. So she has a multifocal lesion, and association with Peutz syndrome with the GI endoscopy, and this is also treated as AIS. This is a review article I was talking about published in Pathology, where they have given that we can have all range of tumors in gastric HPV independent lesions. In vagina, it is the vaginal adenosis of gastric type, which is benign. The possible malignant will be atypical adenosis, and malignant counterpart will be gastric type adenocarcinoma. In cervix, again, this LAGH without atypical is benign. Atypical is along with adenocarcinoma in situ is pre-malignant, and gastric type adenocarcinoma is malignant. Same way, the lesion can be in the endometrium. Now, is this lesion is invasive or not? Again, the dilemma persists. So I feel invasion is less likely because even after 1 year of abnormal smear, there was no progression of the lesion, and PET is negative. Again, invasive cancer is a possibility because maybe it is a small lesion in cervix or has a mucinous profile. So, but more likely, invasion is not there. So, final diagnosis, if I narrow it down, I will go first for the AIS HPV associated, which could be intestinal or smile, with coexisting high-grade cell of cervix and vein 3 or 4 vagina with or without multiple lesions. Second diagnosis I will give as gastric AIS HPV independent lesion of vagina. Now, I'm really maybe incorrect. I do not have this. And whatever the diagnosis is, let me tell you, the type of surgery is again going to be great. What 26 years, what surgery you will give up, it might be so radical for her. So that's the beauty of medicine. It is a constant oscillation between the sharp and the dull. So I'll leave the case as it is. Thank you. Thank you, ma'am, for an excellent discussion. I now invite alternate diagnosis from the audience or questions for Professor from the audience. If not, then I invite Professor Neena Malhotra and from the treating team to discuss the workup. This is just for workup.
Yeah, very good afternoon to one and all. I'm sorry for the delay. I was busy in the Sims plan. Thank you, ma'am, for this excellent presentation you made, and I think you really opened a lot of possibilities which were there, and of course you really tackled it well. Yeah, it was a difficult diagnosis for this girl who had self-referred to her, and she came from a different part from India. She came all the way from New Zealand, and she had known that not just that her wait list was long, but she was not very confident in that country for a diagnosis. And how things moved further, I would ask Seema to share at this point in time and how we planned with Shami. We had discussions, a multidisciplinary team which went ahead and finally it was a difficult point because when we were doing the surgery, it was radical with the diagnosis, what options we had to. There was a lot of deliberations and talking that went because she was a very well-read woman. I think she had Googled and done a lot of PubMed search for us. That was the most. So there were a lot of back and forth, and I think Seema to move forward.
Management was right from the very beginning, and I didn't know where it came specimen of phone from. It is from New Zealand. It's my family.
So maybe Seema, you can move forward and tell us how we went through.
So, as Nan said that she gave us a little more, kind of analysis, and I'll start, ma'am, where did you end? You see, you don't have the eyes of a microscope, but I would say that you have a brain of a microscope. Truly, you reached, the way you dissected the whole case and reached to the conclusion, it is amazing, ma'am. Thank you so much for teaching us so well. It was really good. And yeah, so before we proceed further, one mistake I would like to submit here in the case, the two PET CTs, ma'am, the date was a little bit, I think, wrongly written, a clerical mistake. It was not April, the first one. It was almost 5-6 months before. So we didn't do it so repeatedly. But that was one mistake I wanted to submit.
Yeah.
Given the case has a negative perception, you have many possibilities. You have not.
Yeah. So as ma'am said, ma'am, you have already addressed all the challenges that the treating team, as ma'am and me, we were all doing it, and then we had Dr. Mathur, Dr. Shani, ma'am, Dr. Smita with us, who were kind of doing brainstorming with us. Because as you said, invasion could not be ruled out. So till the end, till the OT, we could not rule out invasion. There was no way that we could rule out invasion with this particular condition. She was a young girl who was totally in the denial mode. She was told about the diagnosis previously, lot of discussions with other centers because she came from New Zealand, as ma'am said, and she was consulted by radio conferencing with other super specialty centers across the world. But she was totally in the denial mode, not wanting to accept the diagnosis. 26 years old, wanted to preserve fertility, sexuality, everything. So she had a very rare histopathology, as we've already pointed it out. So with this aggressive histopathology, which was such a rare entity, we didn't have enough literature to decide how to prognosticate her exactly and how to actually treat her. So these were many dilemmas that we had. And extent of disease, you could see that there was a lot of skip lesions, as you pointed out so well. So all those skip lesions, possibility of invasive disease, the desire of the patient, and the unpredictable behavior of this particular entity made it really challenging. Over to you.
One question regarding the gender. Before the what is the take of the what is likely to be and you are arrived at a conclusion that it is more because of the middle society. Can you totally rule out of course for this maybe or this regarding the involvement of the violence clause? This kind of expensive vaginal involvement is the usual thing about this case. Would you associate that more with the genital imaging or
See, if I get only the corpuscopic imaging, and I have been doing corpuscopic since 1984, it was my thesis topic. And I will give a single line, not going into the literature, that there is a focus of imaging mix and it is extended to vagina straight. So that is the first impression comes to your mind. If you don't have any history, only have the corpuscopic images. And if now the form has been done, and, second, vaginal extension, I have not seen adenosis presenting there. For me, that's why I added the first diagnosis vein. For me, it is vein. That is twins, not gland. If there is a glandular lesion, vaginal adenosis, that is patchy. And few lesions will change into clear cell, not all. So having a breadsheet appearance, so we all of the I've seen in vein. And BFM vaginitis, mostly these are after distraction we've done for CIM. And we get residual vaginal lesion, or it occurs after many years, it is vein. But I've not seen the actual lesion in vagina like this.
you're more be associated? Thank you.
Thank you, ma'am. Thank you, everyone. I now request Dr. Ma'am from Radiology to comment on the MRI findings.
Thank you, ma'am. I shall be telling the MRI findings of this case. These are the sagittal images through the uterus and cervix. Here in the cervix, we are not seeing presence of any mass or abnormal signal intensity. And these are the coronal sections through the uterine body. These are T2 weighted images. And this is the axial section through the uterine body and fundus. Here just we can see an incidental finding of hypointense regions in the myometrium, which are almost continuous with the junctional zone. This is a region of focal adenomyosis. Now coming to the axial sections through the cervix. Here in these images, we are not able to see any abnormal mass, any abnormal signal intensity, abnormal enhancement, or abnormal focus of diffusion restriction in the cervix. Axial images through the upper vagina. Here also there is no presence of any mass, abnormal signal intensity enhancement, or any diffusion restriction. So MRI was pretty much normal, except for the incidental finding of adenomyosis.
Thank you. Thank you. Dr. Suneja, sir, any comments on PET scan and nuclear medicine?
I think in gynecological malignancy, it's very important to have proper medicine, like post lesser is very important. This is just for the information because most of the gynecologists are sitting here. After I'm sharing this information, because most of the time urinary activity in the bladder, in the urethral tract, that remain there and that hide the mainly. So in both the cases, I think the pregnancy was having more activity in this area because physiological activity is still persisting in that. So it is very important to do the lesser patient after the initial imaging and then followed by that we take the delayed images. That will give us a better idea. This is like sun and star. When there is sun, we are not able to see the stars. We have to wait for the sunset to see the stars. So similar mechanism follow here also. So that negative in this case may not be because of that. Just for that came with one of the reason. Number two, the madam has already explained that the reason may be less than 5 mm. So, or maybe the 10 mm in the machine which are older than that. So that may be the reason that the PET CT was negative.
Thank you, sir. Thank you everyone for your comments. Now it's time for the pathology discussion. So for this case, we had received a total of 3 samples. The first one was a biopsy from the cervix along with the vaginal biopsy. And this was a pretty adequate cervix biopsy, which was in 4 large fragments. And apart from this one, which is slightly devoid of lining epithelium, the other 3 fragments are shown lining by nice glandular type of lining epithelium. There is no squamous lining anywhere. And I'll be starting with this busiest fragment over here. This is a closer examination of this fragment. Again, you can appreciate the glandular proliferation. These are some compactly arranged glands, although they are a bit fragmented. And again, we are seeing compactly arranged proliferation. Small size glands, and you can see the maintained lobular architecture in these areas. And on intermediate power, appreciate that the nuclei are not basally located. Instead, the cells are becoming more columnar, and there is quite a cytological uniformity to this. There is no pleomorphism seen overtly at this power. Same here, no pleomorphism, and they're quite monomorphic, although they are columnar cells. Okay. So in the areas of architecture complexity, where there was some intraglandular proliferation, tufting, some cribriforming and papillae formation, here you can see that there is some nuclear. So here you can see that there's some nuclear disarray, some open duct chromatin with conspicuous nucleoli, and again another intraglandular proliferation with papillae formation having fibrovascular pores, and see the mixture of cell type over here. So not just the cells with voluminous clear cytoplasm, we also have some goblet cells like having flask-shaped intracytoplasmic mucin. So this was also observed in these cells. In the other areas, we were finding cells which are relatively devoid of mucin production, and these cells, they were nucleus pseudostratification because it was starting at the same basement membrane. However, the nuclei were seen at different levels. Now, because of this architectural atypia, we started to look for cytological atypia also. And I think in the areas of architectural atypia was where the cytological atypia was also starting to appear in the form of nuclear overlapping, some pleomorphism, and occasional mitotic figures, although they were typical. So this is the largest fragment in the biopsy. Again, we can see that the disease pathology is completely limited to the epithelium. The large chunk of stroma here is sitting quite silently without any abnormality in it. And in these areas, we had significant degree of inflammation, chronic with some edema and fibrosis. Areas of glandular or the globular architecture, which were low-grade areas, have also seen. And the atypia was most striking in these areas, although this could be because of the accompanying inflammation that was there. Again, scattered mitosis and some karyolexis on searching. So based on this abnormal cytological characters and the goblet cells that were seen, we went ahead with a mixture of mucin stains, which is the Alshan blue and PS stain. And unlike the endocervical cells, the non-endocervical cells, which pick up the stain in a very deep blue color, the cells here were more magenta to pinkish in color. Another interesting finding was that the mucin was restricted to the surface of these cells instead of extending intracytoplasmically. So this was another abnormality detected on the stain. We went ahead with some immunostains because of the scattered goblet cells, and the CK20 stain was completely negative, which comes positive in the colorectal tumors, and CK7 was brightly and diffusely positive. Now, PAC8, which is a Mullerian marker, positive in endocervical glands, even normal endocervical glands, was negative in these cells, and here I've highlighted the internal control, which is the B lymphocytes. So this was negative. Since there was some atypia, although mild, we went ahead with a Ki proliferation index, and in most of the areas it was quite low, like you can see here. However, in the areas of cytological atypia, there were certain hotspots identified, like you can see in this image. So this was the maximum Ki proliferation index that you could find in this slide. So broadly, we had an organized or pattern of proliferating mucinous cells, which was restricted to the inner 1/3. There was bland, most of the cells were bland, although there was mild atypia, occasional mitosis was seen, and some inflammation was identified. So the features were between that of a benign mucinous glandular proliferation as well as a malignant glandular proliferation. Hence, amongst this long list of glandular lesions in WHO, these were the relevant differentials that we considered. Clear cell carcinoma and clear cell carcinoma in situ was excluded because these cells clearly had intracytoplasmic mucin, while clear cell carcinoma cells do not. So we went about excluding each of these differentials. Tunnel clusters was easy to exclude. These are usually very dilated glands with flattened cells rather than the cuboidal and the columnar cells that we were seeing. Microglandular hyperplasia, another, it is easy to exclude because of the lack of the reserve cell hyperplasia and subnuclear evacuation that is seen in these lesions. So this was absent from the current case. Then mesonephric remnants, again, we could easily exclude by the absence of these thyroid-like intraglandular secretions, which highlight beautifully with PAS, and we had performed that stain and this was not seen. Another differential which I had considered was endocervical glandular hyperplasia, which is of two types. The diffuse type, this was excluded because the diffuse type usually has a lamellar proliferation of these glands, which is there in a linear manner, a stratified manner, which was lacking in the current case. Lobular endocervical glandular hyperplasia, on the other hand, was a differential microscopically because the characteristic feature where we have these centrally placed dilated larger glands surrounded by these smaller compactly placed glands was seen. However, this type of lesions characteristically lacks nuclear atypia and mitosis, which was seen in the current case. So, digging up literature, there is an atypical lobular endocervical glandular hyperplasia which can show these features in the form of architectural and nuclear atypia along with mitosis, and this type of lesion was seen in the biopsy. Moving ahead with the malignant differentials, since the glandular proliferation was restricted to the pre-existing architecture and there was no confluence, invasive carcinomas were not considered, and we were between the adenocarcinoma in situ, which is broadly classified as HPV associated and HPV independent. And we know that HPV associated has a very intricate association with this particular type of morphology, which is, striking nuclear atypia, a lot of stratification rather than pseudostratification, floating mitosis, and a relatively mucin depleted psychology. So these were not seen in the current case. In fact, if we look at the AIS HPV independent type, most of these features were seen, including the presence of goblet cells, which can be there, and cribriforming and papillary intraglandular complexity, which has been described in these lesions. IC-wise, obviously these are defined by the absence of HPV or absent P16, absent of patchy P16 staining. But apart from this, we can also perform pyrotic gland markers like HIK1083 or MUC6. This marker is currently unavailable in the lab. Other markers which are helpful is ER and PR negativity or at the most weakly positive, and these two markers are usually positive in the benign endocervical glandular proliferations. Another marker which these lesions show an abnormality in is P53. So with this, we went ahead and applied these stains. So MUC5AC was positive in these lesions, which can be positive even in the usual type of endocervical adenocarcinoma, but this marker, MUC6, which indicates a gastric pyloric type differentiation, was positive in these cells. CDX2, another intestinal marker, was negative, and ER and PR both were negative, and we can see the intact internal control, which is in the form of nuclear staining in the spinal stroma. Now, this was the most helpful marker which helped us to clinch the diagnosis, which was an aberrant or an abnormal overexpressed P53 immunostain.
You can see that it is positive in the entire lobule, and it's quite strongly and diffusely positive in all these cells. As expected, morphologically, P16 was negative in these cells. So, morphology and IHC both were in keeping with the AIS HPV independent type. So, distinguishing between these two lesions, the AIS HPV independent type and the atypical hypoplasia, is difficult because they share not just similar morphology but also similarity on mucin state. But this P53 abnormal expression is the one which supports diagnosis of GAIS over atypical LGH. Although both of these are part of the same disease spectrum in these. So, a vaginal biopsy was also received with a specimen in multiple fragments, few of which had devoid of lining epithelium. However, this larger fragment had a big chunk covered by squamous mucosa, which was hypoplastic, acanthotic, and there was some downward proliferation of these squamous cells, which were reactive, and because the surface maturation was maintained. Since we had an MDT discussion and the areas were seen extending deep into the vagina, we went ahead with several cuts, and now these atypical glands, similar to the ones seen in cervix, were now creeping up beneath the epithelium in the superficial part of the lamina as well. And this is just more psychological microscopic pictures of the same. They have the same gland architecture. Even the glandular lobular architecture was maintained in these areas. And IC-wise, they were identical in the form of P53 overexpression and P16 negativity. So hence, the diagnosis was adenocarcinoma C2, HPV independent gastric type, which was I'll go ahead with the other two specimens that we have received, which were vaginal biopsies to know the extent of disease involvement. And we have received 3 biopsies. And apart from the one from the anterior vaginal wall over 1/3, the other 2 biopsies showed complete replacement of the squamous lining by the same proliferating, bland, low-grade pyloric type glands, which had this magenta neutral mucin on special state. Again, the left lateral vaginal biopsy also showed similar findings. The Ki67 continued to be low. There was no invasive foci that was identified. Subsequently, this patient underwent resection in the form of a modified radical hysterectomy, bilateral salpingectomy, and total vaginectomy. And these are the gross images, pre-fixation and post-formal fixation. And dimension-wise, it was within normal limits. The endocervical canal was tunnel shaped, slightly dilated, maybe because of the previous colonizations that this patient had undergone. But what is striking is, or rather lack of which is striking, is that there is no growth in the endocervix, in the ectocervix. Endometrium is perfectly normal. The vaginal rubrosity mucosa appears normal, although there is some congestion in focal areas. Most of the, since we didn't find any well-defined growth, we decided to all omit and submit the entire cervix and along with the vagina. And large areas were showing this ulceration and erosions with some foreign body giant cell reaction and foamy histiocytes, possibly in response to the previous surgeries and multiple biopsies that this patient had undergone. And all of the sections were showing similar findings. So I will show scanned images from one of the representative sections. Yes. So this particular section has been taken from the cervix, including the ectocervix, the fornix, as well as the vagina. And you can see the transition from the more connective tissue-rich stroma of cervix to a more muscular type of tissue of the vagina. So let's start with the most proximal aspect of this section. And here, this is where we could see some of the preserved native endocervical glands. And this is what the endocervical glands are supposed to look like. They have this basally placed nuclei with this pale blue sort of cytoplasm. And as we go along, this is the area of transition of the 2 epithelial types. We have the normal type of endocervical glands transitioning into these cells which are more haphazardly arranged, and the cytoplasm is more eosinophilic. There is some nuclear atypia, some multinucleation which is coming up, and these areas were seen extending throughout in a contiguous manner, although they were interrupted by areas of erosions. And in the fornix as well, we could see similar type of normal glands showing intraglandular proliferations and tufting, and these were seen right through till the vagina. Right, so same type of glands, and I'll also show the special stain with it. Yeah. So again, this is the combined alginate plus blue stain, and I've gone directly to the area of transition.
where from the deep blue mucin that is seen in the native endocervical glands, we have this neutral type of magenta colored mucin, which is so characteristic of gastric type lining, and we can see that the same type of glands are seen in the inner part of the wall, and these glands are nowhere present in the entire wall thickness. There is no invasion. Right. So what about the atypia that we had seen in the original biopsy? It was much more pronounced in the resection specimen. You can see some intraglandular proliferations, papillae formation. The atypia was definitely easier to identify. You can see these large nucleoli that are coming up, which are almost staring at us. And apoptosis or karyolexis were also easily identifiable, along with occasional mitotic figure. We threw some of the same immunostains, and gastric pyloric type mucin stain was positive again, along with negativity for P16. Paxate was negative, and this is the internal control of the native endocervical glands, which is positive. CDX2 now was positive in these cells, although focally. The margins were all negative, free of the AIS lesion. The nearest one was at 6 o'clock at a distance of 4 mm. This lesion was not seen extending into the endometrium, lower uterine segment, or the myometrium, and the bilateral fallopian tubes are normal except for some paracysts. Hence, our diagnosis is adenocarcinoma in situ, HPV independent gastric type, with extensive involvement of the vagina in a contiguous manner. All margins are free nearest 6 o'clock, and the endomyometrium and bilateral tubes are also free of tumor. Yeah, so coming to the discussion, or what was so interesting about this case. First is that it is a rare disease, finding only on a hysterectomy specimen with very subtle histological features. The other was the association of this atypical lobular endocervical glandular hyperplasia that we found in the background. So this has been well documented, and like I said before, these lesions have similar histological as well as mucin stains, and they also have an identical genetic characteristic. But what is striking is the P53 immunopositivity in the adenocarcinomas and negativity in the lobular endocervical hyperplasia. You can read about the spectrum of these gastric type lesions developing in the cervix in two beautiful review articles, which I've referenced here. Now, how common was finding only AIS in a hysterectomy specimen? So that was the question. The largest series that I could find was that of 9 cases, which had quite a number of similar features to the current case. First was that in their cases, the lesion was extending proximally and involving the lower uterine segment at endometrium, although vaginal involvement was not documented. Pure gastric type lesion was seen in 4 cases. Others were more intestinal type. IC-wise, they had a similar profile. And what was an interesting observation made by the authors here was that with the advent of HPV vaccination, there is a relative rise in the incidence of pre-malignant as well as malignant cervical glandular lesions with this gastric phenotype, which may be missed by the HPV-based screening program. So this was something which was a food for thought. Now coming to the exact scenario that we had an adenocarcinoma in situ with extensive involvement of the vagina. I could find only 2 cases on this. This has been reported twice before. First was way back in 1979. And in this case, they described this as a pagetoid invasion of the squamous mucosa. So in their case, the patient had both squamous carcinoma in situ as well as adenocarcinoma in situ. Hysterectomy was done. About a year and a half later, the patient had vaginal lesions and the same type of cells, the adenocarcinoma in situ cells, were replacing the entire vaginal squamous mucosa. And they've hypothesized that it can either be because of a contiguous downward extension of the cervical tumor or malignant transformation of pre-existing vaginal adenosis. Another case report was of similar pagetoid adenocarcinoma spread to the vagina, and this one was P16 related. It had occurred in a HPV positive setting. Now, carcinoma in situ of the vagina occurring secondary to cervical lesions is actually well documented, although this article had not given the histological type. So, as you can see, most of the carcinoma in situ of the vagina are occurring secondary to involvement by cervical neoplasias. This was interesting. And like ma'am has mentioned in her talk also, there is growing literature coming up on primary vaginal gastric type adenocarcinoma and precursor lesions. And this recent article that I think ma'am had also referenced the same one. This describes these lesions within the endometrium, within the vagina, and within the adnexa. But what is common to all these, the common message that they all had was that we first need to exclude tumor metastasis or direct extension from another primary site, such as the cervix or colorectal, which was seen in ours. On the other hand, extension of the AIS move proximal has been reported before. There are few case reports on this as well. And in this series of 4 cases, one of the cases was a gastric type adenocarcinoma, which had spread more proximally and was colonizing the endometrium. And this observation, although not seen in the current case, but has been observed previously in another case of gastric adenocarcinoma, which had an in situ component and was seen involving the endometrium and growing over the endometrium without really invading it. So this was an interesting thing that the proximal spread has been documented. Related to the molecular features of gastric adenocarcinoma in situ. So KRAS and STK11 occur early on, while P53, CDKN2A are the mutations which occur later on in the spectrum from atypical LEGH to gastric adenocarcinoma in situ. And some of the largest studies on sequencing of these gastric type cervical adenocarcinomas, this was done on 68 cases and this one on 14 cases published in the same journal 2 years apart. They show more or less similar features in the sense that P53 is the most common mutation in them, followed by CDKN2A, and STK11 is quite a distinct mutation for this site and can be used to distinguish metastasis of this tumor in a metastatic scenario also. Others like DNA damage gene, DNA repair genes, PIK3 pathway were also found to be mutated. The second study also had documented HER2 amplification in 20% of their cases. We had attempted a HER2 INC on the current case also, although it was negative. And this finding needs further investigation and performing on more cases before it can be of clinical relevance. Very, very briefly about the management of these tumors. Once these are diagnosed, they need to be excised either by loop or lead fixation of the transformation zone or by lead. And then margin status is what determines the further management. If the margins are involved, then even a hysterectomy can be planned. If margins are negative, and fertility is desired, then a conservative management can be opted for. And there is another systematic review on this, where they studied 35 studies, and they found that even after colonization had negative margins, that there was a minor recurrence rate of 3%. And this was because of the multifocality of this disease and the anatomy of this site, because of the long and tortuous invaginations of the endocervical mucosa, that the exact extent of lesion may be missed, or inadequate histological examination of the third scenario. Hysterectomy is the standard definitive treatment for AIS in women who are non-desirous of preserving. I think that is it from my side. I will thank you all for your patient listening and congratulate ma'am on getting the diagnosis very accurately without a microscope. I would also like to thank these people who helped me prepare the CPC and Dr. Amita who helped in all.
Madam mentioned in her comments that the doctor who conducted first patient was intelligent. I must say that the doctor who was made after that and the doctor who was invited for the CPC all were intelligent.
And now invite ma'am, can you please discuss for the management and follow?
Yeah. First, can we just change the presentation? Yes. So as has been discussed very nicely by both the discussant and the pathology team, a few more things we would like to highlight as we were discussing the challenges in front of us. Now with the diagnosis on, we all know it's a very, very rare tumor, a very rare entity than another tumor. Risk of invasive disease is many-fold. How does it go forward? Yeah, risk of having an invasive focus is many-fold. And the patient had extensive lesions, skip metastasis. So this particular entity, the gastric type AIS, HPV independent, is known for having skip lesions not only to the vagina, but also endometrium, tube, ovary, even peritoneal metastasis. So these things are all known. So this explains that why all the imaging and repeated imagings to know whether they are dealing with any invasive focus. Now, regarding the preservation, now the challenge in front of us, how much should be oncologically optimum, how much to remove and how much to preserve. She's a young girl, we wanted to preserve her fertility, sexuality, ovarian function. All these things were supposed to preserve, but not at the same time to compromise her oncological outcome. Finding out invasive disease is not possible with the kind of appearance our patient had. So we try to do everything without compromising the outcome. And so when we discussed amongst us and we decided for the procedure, we decided to go for an ovarian tissue cryopreservation. I went to ma'am and ma'am told me that we will do ovarian tissue cryopreservation. So there was nothing which was there, and it was really not possible to kind of go in for a trachelectomy, that too with this kind of histopathology, which was not proven. There's no proven evidence to go for a trachelectomy in this particular histopathology. So I'll request ma'am to please highlight about our perspectives on ovarian tissue cryopreservation.
Honestly, we were also not very sure whether we should go, because ovarian tissue cryopreservation is something which we try to do for women where we're doing such radical surgeries. We need to be out with their ovaries, or they're maybe later needing some kind of an adjuvant therapy like a radiotherapy where the ovaries will be knocked off. And we knew that this girl was very keen. The intent of cryopreserving the ovarian cortical tissue was at a later stage when she's free of disease. In this case, it's a widespread disease. We could go back and put these for her endocrine functions. Was these grafts, when grafted back, which is called as autotrophic transplant into the peritoneal cavity, host helps them to last with these endocrine functions for 5 years. And since we've taken multiple grafts, we could do that. The other thought this girl was, and I discussed very thoroughly, we had to follow the very strict criteria in which we know that the girl has at least a 50% chance of 5 years survival, which we were not very sure, but we went ahead and did it. Was it in case she wants to go for a surrogacy? Because the uterus is out, will that be a possibility? And we gave her all that reason that in the present day article, it may not be an option, but then she was very keen, and therefore we cryopreserved the ovarian tissue. The good news is the disease is not widespread, so ovarian function will be there. But at that time, there was a lot of skepticism whether we will be really needing to remove or give a radiotherapy. So we've done the OTC, and that was the intent of it. So we will wait and see how she has it. This is how we did. We took, at the time of the surgery, I took thin slices from the ovarian cortex, and this ovarian cortex was then further done by my PhD students, Pathology. Here, we do it by a slow freezing process of tissue. Cryopreservation is slow freezing, and we have a slow freezer with us, and we've stored these tissues with us as part of our program that we are running on.
This is a small video we have. This is a laparoscopy, because this patient's video was not clear, so I thought we will just put in this laparoscopic image to show the procedure.
So we're doing the same procedure at laparotomy as we're doing a laparoscopy, because this was the girl of a C rectum who had come. So we just thought we could show. You just take thin slices. We're doing OTC even in young girls who are going for bone marrow transplant with thalassemia, and those pediatric adolescent girls. We're removing the whole ovary, and these ovarian tissues that are taken were similarly taken at the time of laparotomy, and these tissues from either ovaries are then taken and cut in further slices and then processed and stored. Thank you. Any questions? I think there will be a lot of questions that will be to the clinical team and the pathology. We are here to take them. Sure.
After the vaginal reconstruction was done.
Yeah, we're just showing ma'am the images we have. Yeah. So these are the we went through a conventional midline open approach. The first step was to open the spaces and to assess if there is any kind of hidden parameter involvement or any large nodes that need to be frozen. So we did not find anything untoward after the inspection of abdomen. After creating the spaces, we went ahead with a type B1 radical hysterectomy and total vaginectomy. This is how it looked like after removal of the anterior vaginal wall, and this is the posterior vaginal wall which was removed, and this was the pelvis. These are both the ovaries that were preserved. Then, at the completion of procedure, we approximated the peritoneum from both the sides, and then for the vaginal reconstruction, we planned for a pedicle graft, but then surgery was already long, and then we did a vaginal reconstruction with split thickness skin graft from her right thigh, and this is how it went off. And now it made her vagina very well. She was a young girl, she was very educated, informed, and was very keen on it, so she kept on doing the dilatation and she kept on follow up. And this is how the surgical specimen at that time looked like. And pathology we already discussed. So she came to us every 15 days and then every 1 month, and we looked for her healing of the local wounds, the vaginal part and the thigh wound. And there was no, then gradually she resumed her local activities, and after 3 months she traveled back to New Zealand, and there she's now under consultation with the local gynae who did her previous school, and she's free of from disease, the vagina is okay. So this is how we constructed it. So I think with this kind of treatment, we could give her preservation of sexual function, ovarian function, and the reproductive function, and removal of all the disease.
Was it loaded into trans post ovaries? In how many cases the transplantation will be successful?
OPC is now recognized not an experimental in the level of evidence. It's accepted. In terms of transition, we have been doing it. We learned the number of babies that we want after we don't know like after OPC, not in the so the experiences that come after and IVF. We put back these will have we have this 20 days a week. India's population is very not a America and Israel have one or two spot again are the challenge to do it. But of course now they will be so happy. But the problem is the always last time. So you buy the bureau, it's not the only so. It's my experience not we want to know only shop will be
wanted to say you may want to do an extensive sequencing of germline mutations before advising donor rate rather than only.
There will be here in mind to do this. I think should be again. If you look at the there is one single story that we have actual back
There might be germline mutations which would be predisposing.
Given the law in India, I think you are your you might and the chances are so low. I'm sure it's still
standard recipe that we have to
To say that excellent teaching in case of very close. We see that put very convince us about excellent discussion today. Very good presentation by Dr. Ridhi Sood. And I must say, it's easy to it seems simple just to do that. It was very difficult to really convince ourselves what the things. So, and regarding we are having discussion regarding this case. This is very difficult. What is going to be there in the vagina? And then multiple times showing the same thing. That about the surgery, I think you discussed with me regarding should be the frozen margin for the dissection. I said don't say because frozen and then go environment of organs. So I think excellent management. Very good. Really does this proud. And I think managing so perfect. This is the best anybody could.
Thank you, everyone. Thank you so much.